afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on slowing the spread, a risk-based case prioritization model to manage surging cases of COVID-19. My name is Richard Mather, and I'm a public health physician here at PHO, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. The discussion question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I'd like to state that as the moderator of the session, I do not have any potential conflicts of interest to declare. It is now my pleasure to introduce the speakers for today's presentation: Scott Chalua, Andrea Main, and Jennifer Clark. Scott is currently an operations chief for York Region Public Health's COVID-19 response and the acting director of the Infectious Diseases Control Division. He has over 14 years of experience in public health and social policy, with the last 6 years spent in infectious diseases control. Andrea is currently an operations chief for York Region Public Health's COVID-19 response. When it isn't a pandemic, Andrea manages the control of infectious diseases and outbreak management program, which is responsible for the investigation of cases, contacts, and outbreaks associated with diseases of public health significance. Jennifer is a registered nurse who has worked in public health for 18 years. Over her career, she has developed a passion for continuous quality improvement, aiming to support the implementation of innovative strategies wherever possible. During the COVID-19 response, she has acted as a manager to the Strategic Operations Support Team, working in collaboration with the teams across York Region's response to maintain an agile response with a focus on quality. I will now turn it over to Scott to begin the presentation.
Great, thanks so much, Richard. So we're here today, as Richard's mentioned, to talk about our case prioritization model that we use to manage surging cases of COVID-19 through the third wave. So this document was created by its author, and there's it's been published on the Public Health Ontario website, and it'll be available after the presentation. Since the beginning of the pandemic, York Region Public Health's operational response components of case, contact, and outbreak management. Achieving this, though, required that we built staff capacity, we leveraged all available resources and technology, and we worked continuously to develop and improve processes and strategies across the response to realize efficiencies and the quality of work completed. As the surge of the third wave began to grow, it was apparent that our resources would be strained. With the ongoing goal of reduced transmission and a focus on our most vulnerable settings, work was completed to implement evidence-informed strategies to respond to rising case counts. In April of 2021, a stepwise case prioritization model was implemented with York Region Public Health, and coupled with our successful vaccination response, the approach to case prioritization supported ongoing contact tracing practices, and York Region ultimately experienced a rapid decline in case counts through the second half of the surge. Throughout this all, we were guided by a quote from our medical officer health, Dr. Krim Kurji, who stated, "Effective case and contact management is how we will blunt the curve." Our presentation today will give you a high-level overview of York Region if you're not already familiar. It'll review the strategies implemented during the previous surges and the lessons learned through these efforts. We'll outline the evidence reviewed and the analyses performed to identify additional approaches to prioritization. We'll explain the methods used to implement the prioritization model. We'll summarize and review the approach, and then we'll highlight considerations being made to prepare for any upcoming surge, as well as the stabilization of the overall COVID response in York Region. So our learning objectives would be to identify the variables in which COVID cases may be prioritized for investigation at the local level. We'll describe how York Region leveraged the case contact management system to prioritize cases during the surge of the third wave. And we'll also consider how to develop an agile approach to case investigation, enabling an effective response to an evolving local situation. Our first poll question is, in your experience, what barriers existed within your organization that limited case contact management practices during surges in case counts? And the answers are available human resources, system structures, case complexity, challenges with cases adhering to self-isolation requirements and public health measures, competing priorities, and other. And if there's other, please feel free to post it in the chat. Very similar challenges that we face locally with the available human resources, as well as also the system structures to manage the workflow, in addition to case complexity and competing priorities. So great to see that we aren't the only ones experiencing those challenges. So a bit about York Region. At almost 1.2 million residents call York Region home, making it one of the largest municipalities in Canada, It's 1,800 square kilometers that stretches from Lake Simcoe to the north, Toronto to the south, Peel to the west, Durham to the east, and Simcoe to the northwest. York Region is also diverse and growing in size as well as aging. So by 2031, one of our local municipalities will increase by nearly 230% to 87,000 residents. In addition, in 20 years, York Region is expected to add about 660,000 new residents. And this is being driven both through immigration as well as through new births. Each year, approximately 10,000 new immigrants come to York Region, and about 11,000 babies are born every year. And York Region is unique as it has a mix of urban, suburban, and rural areas, as well as direct connections to two 400 series highways and the 407. And the subway already enters, or will be entering very soon, York Region to two areas, Vaughan and the city of Richmond Hill. Since January 2020, York Region has been responding to COVID-19 using the incident management system structure outlined on the screen. Our response has grown and shrunk throughout the response, with nearly 1,000 staff at the peak supporting the overall response in York Region. New additions were added to the response structure as new responsibilities were added. So for example, vaccination clinics and the school focused nurse initiative. As COVID-19 becomes endemic, discussions are ongoing to determine how we respond to COVID-19 while at the same time getting back to normal public health program and service delivery. The temporary addition to York Region's org structure will help ensure we have a robust case contact and outbreak and immunization response for COVID-19, while at the same time allowing for other mandated services to resume in earnest. Despite being in this IMS structure for over 18 months, the case contact and outbreak operational structure on the screen now has remained anything but static. It's ebbed and flowed as the pandemic has evolved and has gone from 100% in office to 100% remote, while at the same time implementing new provincial systems and processes. Nimble is not the right word to really describe the flexibility the response has had. And one of the reasons we're here today is to share some of our findings and actions of what we've done, ensuring that we can stay lockstep, or if we're lucky, ahead of the pandemic. I'll now turn it over to my colleague, Andrea Main, who will walk through some of York Region's COVID-19 story.
Great, thanks, Scott, and hello, everybody. Many thanks to all of you for joining us here virtually in York Region today. Over the next few slides, I hope to share with you some of our experiences over the course of the pandemic when surges in case counts strained our limited resources. So the York Region operational response was initiated in February of 2020 within the Control of Infectious Disease team here at York Region Public Health. On February 27th, we received our first case, a returning traveler. And by early April, wave 1 brought a surge of cases that required us to expand the response until all available resources from public health, as well as staff from other departments of the region, were deployed to support the response. During the first wave, we operationalized COVID-specific teams to separate out the work, and that included case management, contact follow-up and exposures, the workplace outbreak team, and the institutional outbreak team. By late July, we rolled out CCM, trained our teams, and transitioned fully to this new case and contact management provincial platform. And over the summer months, we put everything we could into leveraging this new CCM system to support the work. It was at this time during the summer that our school team was formed, which also included childcare, day programs, and camps. In early fall of 2020, we started to find that our capacity was strained yet again as we faced a second wave of cases. At the same time, we decided to centralize our case investigations all to one team rather than referring cases for investigation to the outbreak teams. In early October, we were grateful to have the support of the KFLA Public Health Unit, as well as the provincial workforce staff to investigate cases during this second wave. And by mid-December, we started to leverage the use of the virtual assistant, just as the variants of concern started to emerge, throwing us yet another COVID curveball. Initially, we were doing a double investigation for cases who tested positive for a variant of concern, and we had a separate team of experienced investigators assigned to calling cases back when their results were received. And then in early January, we stopped using a lot of our side systems to assign out our cases, and we transitioned to using CCM for work assignment and case monitoring, which was a real game changer for our teams and increased efficiencies across the board. Along with each of these different approaches that we used, we worked on improving our surge models, our model levels of investigation. And on the next slide, I'll speak to some of the differences in case investigation during each wave. So this slide demonstrates some of the different strategies that we used during the first 2 waves of COVID. So during the first wave, our case investigators were doing that full case and contact investigation. And as the cases started to surge, we implemented a triage approach where we would call all cases to determine if they were high or low risk, and then prioritize the high risk cases for a more fulsome investigation. And at this point, some of the low risk cases received a letter. And some of the challenges that emerged with this approach was it was very difficult for staff to abbreviate the call. Cases were quite eager at the time to speak with public health when the surge in cases were not, we were not always able to call the cases back, resorting again to sending a letter. So at this point in time, we were managing our cases also using a paper-based system, which added to the challenges of managing that first wave. And for the second wave, we experienced our first significant backlog. We shifted from that triage approach and developed a 3-level case investigation model that condensed the case investigation as case count surged. This enabled us to predict how many staff we would need by investigation type and helped us calculate how many cases per day our staff could feasibly complete. And at this point too, we also started to really leverage that use of the VA and prioritize the cases based on the responses we received. And for the third wave, I will be leaving that to Jen to do the deeper dive in the coming slides. So as the third wave was mounting, the key question that we had was how might we further prioritize our case investigations to really reduce the transmission of COVID in our communities? And to answer this question, we reviewed numerous sources of evidence, including the experiences of our investigators and lessons learned from the previous surges, our provincial guidance, relevant literature, and local data. I will now hand it over to Jen, who will overview the components of the prioritization model, the evidence that inform them, and the strategies used for implementation.
There, thank you, Andrea, and hi to everyone. Thanks for joining us. So, wow, looking at that timeline and going through that's both incredible and tiring, but it definitely sets the stage for us to now take a deep dive into our case prioritization model and look at what we were facing with the mounting cases of the third wave. As Andrea outlined, we definitely had a number of strategies and plenty of lessons learned under our belt at that point. When our public health resources become strained, we must refocus and remember the outcome we are working to achieve. And with case and contact management, the aim is prevention, to blunt transmission and reduce the number of York Region residents who contract COVID-19. So at the end of March, as case counts were climbing and the case management team's capacity began to spread thin, operational planning efforts zoned back in on what more could we do to reduce potential transmission. Before looking closely at our model and what that prioritization ended up looking like, I just wanted to highlight a couple of really key points to keep in mind. So the intention is always to investigate every case of COVID-19 that's reported to us. The shift to prioritization occurs only when our resources are unable to keep up with the incoming cases. At the same time, though, significant effort continues to be made to increase investigative capacity by shifting resources, leaning on partnerships, increasing the capacity of investigators to respond to more cases, and improving processes to find efficiencies, as well as developing new resources to support the work. It's also important to remember that all of this work has been completed throughout the pandemic under extreme pressure, consulting evidence, analyzing data, and developing processes, communicating change, and for those implementing the work, learning these changes, it all happens within days. And even then, it never feels like it's fast enough. So I'm just highlighting this because it's been imperative during the pandemic that we work quickly and that we implement. And while the planning work, often implementing while the planning work continues. So I can imagine that most of you who have been working in the COVID response in one way or another have relied on the analogy of building the plane while flying it. This far into the response, we've built and dismantled a number of planes, and actually it feels as though we have invented a whole new method of transportation. So my point is that the work is not always perfect, yet with COVID, rapid and agile efforts are critical. The virus has proven it is sneaky with lots of tricks up its icky little sleeves. So just pointing those couple of things out to bear in mind. But if we get back to late March, as our capacity was becoming strained, we did move back to our more abbreviated approach to investigations to try to manage to investigate all cases as long as possible. And this includes collecting the critical information that will give us any indication as to where potential transmission may happen, and contacting all cases to collect their exposure information, where they've been during the time that they may have infected others, as well as their close contacts. And one thing that we've really aimed to do in York Region, and fortunately have been successful at doing, is to continue with our contact tracing activities through each surge. And so through our abbreviated case investigation, as well as the prioritization model, we've been able to avoid not collecting close contacts from our cases during the case investigation. Also at the end of March, we went back to sending all cases the virtual assistance survey, which Andrea spoke to. This is a survey that's sent directly from the provincial case and contact management, or CCM, system. It's sent by text, and it informs the case of their positive results, their requirements for isolation, as well as collects key information from the case related to their symptoms, places they have visited during their infectious period, as well as their ability to isolate safely within their home. We've realized great success with sending the survey 3 times per day, and find that cases either respond quickly to the survey upon receipt, or they're unlikely to respond at all. So at the end of March, all those pieces were in place, and it was time to get back to, beyond those things, what else could we do to prioritize our cases? And so we will dive deeply into our prioritization model today, and explore. First, we'll look at the 9 levels of priority by which we sorted our cases. And you see the buckets in the background there. Sorry, you see the buckets in the background there. And the buckets are a theme that you'll see throughout the rest of the presentation. Internally, we often talk about our cases dumping into their appropriate, not dumping, dropping, I guess is a better word, into their appropriate bucket. We'll also look at how the model was implemented and how we leveraged the CCM system to do so. Then we'll look at and consider the impact of the model. So a couple of key considerations were made initially with this work. And one was, there were some questions as to whether or not we should return to a triage approach or outreach approach to our cases, as Andrea described we had done previously, meaning that we would call all cases for a very brief call to collect some key information, and then follow up with cases who identified any real risk for further transmission to do a full investigation. So when we implemented this through the earlier surges, we did recognize some success with that and some benefits to that approach. We were able to make contact with all of our cases, or at least attempt to. And we were able to notify them of their isolation requirements. Also, we're able to quickly identify whether or not they were linked to any of our priority settings. While there were benefits, there were also some challenges with this approach. Often the cases, as Andrea also mentioned, would share more information than we were hoping for, making the calls stretch out longer than intended. Also, it could add some confusion within the team because cases were often calling back, and cases sometimes expressed not being very happy with it because they were talking to numerous people throughout their experience with public health. Fortunately, while trying to decide whether or not we should go back to this approach, we were able to consult with some unique information that we had been collecting from our cases. Upon investigation, the investigators would note whether or not the cases they spoke to were aware of their positive results and had already begun isolation. So when we looked at this data at that point, we learned that, in fact, 98% of the cases we had called were aware that they were infected prior to our contact, and actually 99% had already begun isolating. With this information, we were able to feel confident that, in fact, going back to a triage approach would not bring us the value we were hoping for, and we would have greater impact by continuing to investigate our cases based on risk. Also, in consideration of evidence from the CDC and understanding that the value and the benefits from case investigation come within the first 6 days after a case is diagnosed, or from their episode date, if we had that information available to us. And so we were able to leverage the CCM system to understand the episode date for the case, whether that was based on their testing date when they were swabbed, or their symptom onset, if we had that information from the virtual assistant survey. And so we aimed to make sure that we investigated cases quickly, and we were mindful not to spend the time with cases if they hadn't met that 6 days past their episode date. So this was an approach that we really implemented in the second wave, and it was a strong approach, and it may be a good place to start for health units if the full and really teasing through prioritization is not possible. With this approach, we really tackled the backlog from both ends, from our oldest cases as well as our most recent cases. Daily, we would look to our average number of investigations we were completing per day and jump into our backlog that deep and begin the daily assignment so that we were investigating outwards each day. At the other end of the backlog, for cases who were, it was not reasonable that we would manage to do a full investigation, we were sending the case notification letter and we were sending it out as early as possible, hoping that it would reach the case ahead of their 6-day point. So beyond these two strategies is where we started to look to the information that we had available to us ahead of contacting the case to prioritize. And, we really don't have a whole lot of information. What we do have is their lab results, which come through the CCM system, with mainly their demographic information. And when we're sending the virtual assistant survey, we have the information provided through that. So if we start to look at the buckets of prioritization, our first two buckets are based on cases that are associated with outbreaks. And we learn this in two different ways. The first, and this is our top priority bucket, these cases actually don't even get sent the virtual assistant survey because they will be picked up and investigated as soon as they're coming in. And they are cases that are linked to an outbreak. We understand this because our outbreak team has provided the facility with their outbreak number, and that has been included in the requisition, the lab requisition. So when these cases come through the system, they're already linked to the outbreak, and we can see that within the case investigation in the investigation outbreak object. The second bucket are cases that are suspected to be linked to an outbreak or were present during their period of communicability in one of our priority settings. This is learned, and actually it was really through the second wave that we learned with the school setting that we were hearing about cases often before we were able to investigate them from the administrators of the schools or others in reporting those cases directly to us. And so we do have an intake team on our school's outbreak team who receive these calls through a specific phone extension. And once they learn of that, the school's team is able to create a task, which is attached to the case investigation in CCM. And it flags the case management team that there is a case that should be prioritized for investigation. They fall into our second bucket. Our next three buckets rely on the information that we learned through the virtual assistant survey. On that survey, if a case indicates that they may have had an exposure or may have been present in a priority setting during the time that they could have infected others, then they would fall into bucket 3. The settings of concern that we prioritize are institutions, schools, childcare settings, industrial, farm, or healthcare. And also if the case indicates that they've attended a social gathering or their workplace during their period of communicability. You can see that that's a pretty extensive list. And this is one area, if we are going back to prioritization through the fall, to reconsider based on how frequently these cases, in fact, did lead to transmission exposures, or perhaps were the index case of an outbreak. The fourth bucket was made possible when the virtual assistant survey started to include the socioeconomic status questions, which are collected provincially. Through those questions, cases indicate the size of their household, and we decided to prioritize any individual who identified that they lived in a household of 6 or more people. And this was a piece that, back to this work happens really quickly, and sometimes we are implementing as we're learning more. So I will say that the choosing 6 people was not based in specific evidence. Having reviewed more evidence since then, I think it's another opportunity to be reconsidered heading into the fall. And in fact, likely this fourth bucket should be adjusted to include both number of individuals living within the home, as well as the annual income of that household. With some combination, given that smaller households, if they have a lower income, are likely to perhaps have a greater risk because perhaps they have more essential workers living within the home, or they likely have less space to safely isolate. The fifth and final bucket, based on the virtual assistant survey, is when a case will identify through the survey that they have some concerns related to being able to safely isolate. After we pass through bucket 5, we're now faced with what else can we use? How else could we potentially prioritize our cases? And what other information do we have? So at the end of March, very early in April, as we were considering this, it aligned really with the provincial release of hotspots across the province meant to inform prioritization within our vaccine response. Internally in York Region, additional work was done with those hotspots to really zone in and prioritize, and 5 priority hotspots were identified. So there was some consideration whether or not we should also prioritize our case investigations based on the case's postal code or the area in which they live in York Region. So, thinking back and thinking, is a case more likely to infect others based on where they live? Or are there any other pieces of information that we're left with that may actually be more indicative of how likely somebody would be to infect others? And when we were thinking that through, we really thought towards close contacts and what group of individuals may be most likely to have higher number of close contacts. So we did an analysis to have a look at that, with the objective being to retrospectively assess the average number of contacts per case. And we were organizing the cases based on geography or their postal code, or a term that you will often hear, their forward sortation area, FSA, which is the first half of the postal code, or by their age, which was another piece of information that we have on the case prior to contact. So we pulled and merged case and contact data from the CCM system to identify the number of close contacts per case, then organize those cases based on their residential FSA as well as age to identify the average number of close contacts per case for both groups. We excluded cases that were linked to institutional exposures and outbreaks due to their fundamental differences in investigative approaches, as well as living within the facilities has some different implications for transmission. So our sample was 2,081 confirmed cases that were reported between February 15th and March 15th. And just to remind that February 15th was the reopening of schools in the province. And so this sample of cases represented a time when students were in class. For those cases, there were 6,967 close contacts that were linked. So with the first organization and by FSA, we found that 5 of the FSAs in York Region stood out, with the cases having the highest average number of close contacts. And you can see they're represented on this map in the brighter red color. And so they're distributed, kind of spread out a little bit through York Region. And it was interesting to note that these FSAs did not align with the 5 priority FSAs identified internally for the vaccine response. So beyond the FSAs, we organized the cases by age group, and we found that 0 to 29-year-olds were the most likely to have the highest number of average close contacts. So just to try to think about what this meant, we compared the two and merged them together. So looking at those FSAs that stood out and looking to the age categories, we saw that in fact, the FSAs were really being driven by that lower age group. In order to confirm and validate what we thought we were learning, which was that the younger age category was the one with the greater number of close contacts and likely could be our priority, we did a second sample and pulled cases and contacts from January 15th to February 15th. And although for each age group, the number of close contacts went down pretty consistently by 1 contact per case, we found that the age categories themselves stayed consistent while the FSAs had completely changed. And this really confirmed to us that the age categories would in fact bring greater value in prioritization over the FSAs of the cases. So to really dig into those age categories and understand what we were learning, we divided it into 5-year increments and really saw that our youngest residents in York Region stood out with the highest average number of close contacts. And when we think about this, it makes a lot of sense that our 0 to 4-year-olds have daycare or childcare contacts. They have their household contacts, but we also saw that they had a good amount of community contacts as well. And when we looked at those exposures, we learned that those were really based on their parents' movements or their caregivers' movements throughout the region. These little guys had exposures in nail salons and gyms. And so, that makes sense, requiring constant care. They were in tow wherever their caregiver was going. And then we saw that as kids were getting older, they also had the higher number of close contacts, and then that started to drop. And we saw that little spike in our 35 to 50-year-olds over, surprisingly, the 20 to 35-year-olds. When thinking that through, we have to be mindful that this data is based on the information reported to us by cases. And so it is possible that there may be some challenges with the disclosure of information from our cases. But when looking at the exposures of the 35 to 50-year-olds, it was interesting to note that they really had a lot of industrial or manufacturing type exposures and more than the 20 to 35-year-olds. And we know that that type of setting has been a really high risk setting during the pandemic. So in order to consider what that meant, our analyst ran this exercise looking at the time on April 2nd. We had 520 cases awaiting outreach in our backlog. And so considering in the investigation of 200 cases in a day, we looked at 3 separate approaches to investigation to see what the potential impact of each may be. So if we went with the more traditional approach of investigating based on reported date, and we pulled those 200 cases from our backlog, we were likely to identify approximately 662 close contacts. If we pulled 200 cases based on their residential FSAs aligning with the 5 priority FSAs identified for York Region, we had the potential of identifying 670 close contacts for an increase of 8. If we pulled the cases based on their age, And based on the age categories that we were considering prioritizing, then we would have the opportunity to potentially identify 820 close contacts for an increase of 158. And so with this information, we felt confident that we should prioritize by age category. So our next three buckets, 6, 7, and 8, are those age categories. And that is based on the case's date of birth, with bucket 8 capturing all of the cases outside of the previous 7 priority groups. Bucket 9, fortunately, was only used for a few days, really in the heaviest days in the middle of April. And it would be implemented when we were starting to see a backlog with our 0 to 19-year-olds or 35 to 50-year-olds. And when that was occurring, we would then prioritize those cases in bucket 9 by their residential FSAs and investigating those within our 5 priority FSAs first. And so that really outlines the 9 buckets by which we were prioritizing. But really, when we think about the approach, it's really sound in likely helping us to manage transmission or focus in on the greatest risk for transmission. But if we couldn't implement it easily and we couldn't support the team to implement it properly, we would lose the value it could bring. And in fact, we may impose some greater risk by adding confusion and chaos to the work. So an implementation had to be possible. And there was really there's a number of key things that we've done throughout the response and structures that are in place to support that. And really the entire structure of our overall response with our liaisons, communicating with our partners, our communications and information, our planning team offering data, as well as our team that supports training and development, all key factors in being able to implement any initiative that we're trying. Additionally, we, within CCO and within the case management team specifically, the structure has offered that support of having strong leadership to support the work and for the investigators to consult with, having additional resources to support training and development and to support use of the CCM system, and understanding the practice. Another key resource has been the operations support team, who works very closely with the teams to support their process development and implementation, to develop resources there, to map processes, to identify opportunities for efficiencies, and to focus on knowledge translation. The operations support team has also acted during these times when we're implementing these initiatives as a bridge, really bridging over that implementation gap to support the teams in implementation while the team is able to understand processes or put things in place internally to support implementation. And really, ultimately, the greatest asset and the biggest factor are the frontline staff, those that are doing the work, contacting our cases and collecting the information and supporting our residents through their illness. And without our amazing investigators, none of it would be possible. So with all those supports in place, we can look at how specifically we implemented the prioritization. So I understand you can't read this map, and that's not the intention of showing it today, but we can make it available after the presentation if anybody's interested in having a look. But you can see, even just based on the layout, the complexity that exists. And if you consider that up in the left-hand corner, that is where we receive our cases. And down in the right-hand corner is where the case is investigated. So over a very short span of time, many process steps and decisions represented by the diamond shapes are made. So I wanted to have a quick look at this today, because if you further consider that anything that is in the red color is an automated process step or decision, that's actually now we're relying on CCM, on the system itself to do those pieces for us. And the blue steps are manual steps and decisions that for the most part the sorting of the cases and understanding the situations is automated through CCM. And this is achieved through leveraging the different resources within the system or different tools within the system to organize the work. We use case lists where the system we can put some specific criteria to the lists and the system will organize them to collect the cases initially so that we can mass send the virtual assistant case survey that is sitting there. And then based on the information in the case investigation and the additional information we learn if they complete the survey, we then rely on dashboards. So I know, again, you won't be able to see very clearly, and fortunately, there's nothing there at the moment when we took the SNP, but this is our 9 buckets of priority. And based off of all of those decisions made within the system, the cases will wind up listed here. Within the case management team, they assign cases from top to bottom, and not until the first row or priority box 1, bucket 1 is empty, do they move on to the next. The team mass assigns in the mornings, and they assign each investigator. I think we had gotten upwards of 3 cases per day. And if investigators are able to complete those investigations and they're ready for another investigation, we would come back here to assign again from the appropriate bucket. So the dashboard is great because it shows us what we want to see, but it is really the reports that feed that dashboard and the filters of those reports that are the key to making sorting of the cases possible. So I just pulled the filters from one of the reports, and I think that this is for the priority bucket related to the age category of 0 to 19. And just to show you the complexity of those filters. So we had to set these reports to capture York Region confirmed probable or PUI cases, to eliminate cases that had already been actioned or assigned, to eliminate cases from earlier buckets in the prioritization model, and capture the cases that match the criteria of that specific bucket, while also avoiding cases that belong in subsequent priority buckets. So we created these reports and we implemented the first dashboard for assignment with these specific levels very early in April. But it did require some time for us to continue to look at those reports and filters to see the cases where they were falling and perfect them. So beyond that dashboard, another key piece that supports our ability to prioritize is having the system automate as much as possible our processes for sending letters and for entering data. So the system will send cases that require a letter to a report that is formatted to capture the information exactly as it needs to go into our mail merge and to the mailroom. We also have created monitoring dashboards, which allow the leadership teams to see the work that's waiting, see the work in progress, and see what's happened. So very quickly, looking at the month of April and some of the numbers, we received 11,629 confirmed cases. 85% of our cases successfully received the VA survey, and 47% of those that received the survey either partially or fully completed the form. So really we had just over 40% of our total cases, some additional information. The remainder of, or the next few are related to the letters received from by our cases. And the final one there indicates that over that month of April, we fully investigated 61.4% of our cases. And this graph looks at and is trying to see how successfully we were able to prioritize cases. So you can see that the orange line represents our cases under the age of 19. And on the left axis there, it is showing the proportion of our cases in that group that we successfully fully investigated. The blue line shows for over 19 years of age, the proportion of our cases that we fully investigated. And you can see with that crossover of the lines, the day that we launched our new dashboard for case prioritization. And also you can see that in the middle of the month, in the background, the bars show the case counts that we receive each day. So you can see in the middle of the month on our days where case counts were highest, those lines came close together. And that's likely due to a number of factors, and likely that at those points where we were getting higher case counts, they may have fallen into our earlier buckets. But I would say that mid-month, around April 17th and 18th, where you see those cases, we see that we're prioritizing more of our younger cases, is when we were able to perfect some of the filters that feed these reports. So ultimately, it's hard when you are working in prevention to show the impact, but we're confident that we were able to, with this graph, hit our prioritization. And we also knew that we really fortunately had a rapid decline in case counts as we came out of the third wave. And while this is not solely due to our case and contact management, and also is really impacted by our vaccine response, we can have some comfort in knowing that the case and contact management practices has a good impact on this as well. And we've also been able to be quite confident that we didn't cause any harm in having this approach. So I'm going to hand it back to Scott now for a quick wrap up and look at some future planning before we open up for questions.
Thanks so much, Jen. So York Region's public health response will continue to be nimble and reflect the changing dynamics of the pandemic locally while leveraging all available data to continue to make these evidence-informed decisions. And as we're making our way through the fourth wave, we still continue to remain focused on adjusting our prioritization model to reflect new data and realities. So for example, a highly immunized population, amendments to CCM version 13 and any future iterations, as well as schools being back in session for in-person learning. We're maximizing the use of automation where possible, so continuing use of the virtual assistant, as well as now using robocalls and mass texting, especially in low-risk scenarios, and then remaining committed to leveraging our dedication to continuous quality improvement. This is something that York Region Public Health has been recognized nationally by Excellence Canada for our excellence in this area, so it's something that is a foundation of all the work we do at York Region Public Health, and especially within a scenario such as this, where we're constantly, as Jen said, building the plane as we fly it. We've perfected the dismantling and reassembly in a lot of different areas, but we're always looking at new models and how we can make that plane that much better. And I'd be remiss to say this was done in isolation with just Jen, myself, and Andrea. It definitely was not. So I really want to extend a special thanks to the entirety of our case contact and outbreak operations, from our admin clerks and staff to our case investigators and to the management and leadership team. The thanks go out to them for the ones driving this on a day-over-day basis and really being the face of public health and supporting our residents when they need the most. I'd also like to thank the strategic operations support team under Jen's leadership for their dedication to ensuring that our effective case prioritization helped us out of a backlog and helped us stay out of the backlog throughout the peak of the third wave. And also a special shout out to Megan O'Neill, who really was able to pull this data and analyze and really understand the nuances of CCM and the local epidemiology to really make these decisions and help inform the development of the 9-bucket approach. And finally, to Dr. Kurji, our outgoing medical officer of health, who's retiring in exactly 7 days. His expertise, his calm and encouraging leadership throughout the pandemic has really carried us through. And so we all want to wish him that his retirement repays his entire commitment of his career here at York Region Public Health and to public health in the province in general. So with that, I think we can turn over to Richard to the Q&A portion.
I just want to say thank you to Scott, Andrea, and Jennifer for that presentation. It was, in a way, unfortunately, very timely given the rising cases in the province that may need to have a prioritization model of cases going forward. For all participants, if you could please continue to enter your questions into the chat pod if you have not already had the opportunity to do so. So the first question we received is how many case investigators does the team have?
Thanks, Richard. So the number varies. So we've at the peak, we had nearly 1,000 people working within COVID response. Within the case management team, on average, on a busy day, we tend to have between 150 and 200 people at the peak. Again, this ebbed and flowed dependent on the day. We did maintain 7-day-a-week operations. And then as we were able to build additional supports through the PWF, provincial workforce staff, it really helped us sort of shore up those additional resources that we had. So currently today, for example, we have about 115 people within case management conducting the follow-up calls. And these, we're always looking sort of to shore these resources up so that we can keep ahead of this fourth wave.
Thank you. As a follow-up question to that, were case investigators specialized by age group, for example, a youth group?
No, we didn't specialize by youth groups. So we did have, the way our organizational structure is, we have our general case contact management team, which was responsible for the case management. We have our school-focused nurse initiative, where these are the dedicated nurses funded through the province. And these individuals support childcare center and outbreaks in school settings. And our institutional outbreak team is more dedicated to our long-term care homes, retirement homes, and other congregate care settings. We don't have a dedicated team based on age of the case. Rather, it's central pool of our case managers, and then filtering out to the school or childcare centers dependent on institutional outbreaks, dependent on their attendance.
Thank you. Next question is, can you elaborate on how you're using robocalls? And maybe clarify if that was different from how you're using virtual assistant, or if I'm not sure that question is referring to the same thing.
Yeah, robocalls, we're using them differently than a virtual assistant. So our virtual assistant gets pushed out through PHO, not through PHO, through CCM. Whereas our robocalls, we're using Rave, and it's a process where, given we have a section 22 now in place within York Region for contact lists for anyone having a gathering, whether it's a private home gathering or they're a large gathering at a wedding or a stag. And these individuals, based on the assessment of the exposure and in consultation with our public health physicians, if we deem it to be a low risk exposure, we upload the attendee list, so their names and their cell phone numbers or home phone numbers, into Rave, and then we're able to send out an automated message that goes out to them, providing details of the exposure and the actions that we're expecting those individuals to take. This has been a really cost-effective and manageable way of dealing with large numbers of contacts. We've had a few weddings of 160, 170 people, and so it's a quick way to get this message out, advising of the public health actions to take, as opposed to the traditional way where we would either have to phone each individual or send letters to individuals as well. And through this robocall process, we do get a report exporting the success and or failure of the contact, and those that weren't successfully reached would be followed up with a live person.
Thank you. And as a follow-up to that, well, when you get that report of success or failure, is there a way to know how long a person listened to the robocall, or they?
Yes, the report that we get out of Rave tells us how long the individual. So if it goes out as a voicemail, so if they listen to the full entirety, and there's also people that have listened to it multiple times, because the report would say they've had it or heard it for 5 minutes, for example. So they would have heard it for multiple times. So really wanting to sync that information in.
That's very helpful. Next question is, was there any assessment of secondary transmission by age? You did mention that one FSA analysis, you looked at the number of contacts, but this one's more specific about transmission.
Maybe Jen, I can ask you to take that question.
Sure. Yeah, we shared very brief information about the review that we did following the month of April. And fortunately, by May 1st, we were able to stop prioritizing cases. So it is hard to understand exactly the secondary transmission when we look through the information, because it's really dependent on many variables, including provincial public health measures as to the number of contacts that individuals have. So really looking, I guess, to those contacts that then become confirmed cases. We've done some of that work, but it may be one area that would be great to have a deeper dive into. Although I do think that from the recent literature and evidence that's come out around COVID, we know that younger cases can pose greater risk for secondary infection. And that definitely secondary infection is most happening within the household, which is consistent with what we see with our cases acquisition sources.
Thank you. Next question is, you stated that 98% of people already knew about their infection by the time they were contacted. And the question was just, was this at 24 hours after getting a positive result into CCM?
I thank you. Yeah, when we were looking at that information, we had been collecting it during a period of time that we were not in the position of having a backlog. And so it really was, we were meeting that timely follow-up metric of reaching our cases within 24 hours. So I would say that, yes, it was based on that time period. And I think there's a number of reasons why our cases were already aware of their infection. Of course, there's the provincial opportunity to learn your results provincially on the website. I think that many physicians are informing their patients when they learn that they have positive results. Also, if they were previously contacts, they would have been aware or already isolating based on our contact with the primary case. And we did see, though, that it was interesting at the end of the month, at the end of April, because when we don't have a backlog, sending the virtual assistant survey becomes more challenging because we're kind of case in, case out. And it did see a very slight decline in those rates at the end of the month when we were not using the virtual assistant again, because we didn't have a backlog. And so that did provide some reassurance that in fact, the assistant was providing that notification to some of our cases.
Thank you. The next question is, what type of model did you use with the provincial workforce to assist with case investigations? Did you train them yourselves, or did you use the provincial workforce team that is trained centrally?
Yeah, we have the provincial workforce investigators working directly with us. And so they use the same processes as our internal investigators. And in order to support the consistency and the standardization of approaches and documentation and completing the processes so that the work can move along through CCM, we've developed resources that support both internal and with our PWF group, and they use the same process maps and tools that support documentation into the system.
Thanks. I think we have time for one more question. Do you add all contacts from school setting into CCM for contact tracing purposes, or do you have the school principal send out a letter to all parents with instructions?
Right now, what we're doing is all of our high-risk setting, or our exposed cohorts are being sent to our contact tracing team for follow-up. They do receive a letter as well from public health, so advising of the exposure and the specific actions to take dependent on their immunization status. Right now, just given the workload, we are looking at how do we realign that work, knowing that one of the key things we want to do for the immunized is to verify their immunization status. So it is something that we're looking at the workflow now, just to make sure it's sustainable, as we expect to see more and more cases in the school setting with any sort of increase in cases. So right now we do the sort of Cadillac version, and we may pare back a little bit dependent on workload.
Thank you. So as we wrap up today's PHO round session, I'd like to thank Scott, Andrea, and Jennifer for presenting. It was very interesting and very timely. And I'd also like to thank everyone who joined us for today's session. It's great to see such a strong virtual participation during such a challenging time for healthcare professionals. And you can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. And lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, hit the education and events, and click on presentations. Thank you, everyone, and have a wonderful day.